Hi, how you doing? I think that this is my first Instagram Live in English. I thank you all that you'll be connected, and I'll be talking English most of the times, but if you know they have some questions in Spanish, I'll be more than glad to answer them. And I'm laughing because a few days ago someone was saying that was surprised that I speak English. They thought that I speak only Spanish, and I hope some of my kids are watching this and they discover that I do speak English, but with a strong accent, like they said. So what we're going to talk today is about egg donation and gestational surrogacy. What I will do is first concentrate on egg donation, and we'll talk about what we normally do on this type of treatment and what potentially new things are we doing regarding the coronavirus pandemic. The egg donation is a treatment in which a woman donates her eggs. Basically, she will have to go through the in vitro fertilization process for us to aspirate as many eggs as we can get. And all of those eggs are going to be donated to one particular couple or patient by itself. We do not do egg sharing. We used to do it in the past, but doing that type of treatment, we thought that we are not benefiting all the parties that are involved, and we stopped doing it. Still in several places in Latin America, they are still doing this, but we don't think that is on your best interest. Many patients are asking if it's better to do and to utilize frozen eggs. The main advantage, and probably the only advantage to use frozen eggs, is the availability of those eggs. What happens is that in that type of treatment, the eggs are already frozen. They are in a bank, and you can order them, and you will have them in our center in a few days. And that's really the only advantage that I think that you can say that is for this type of treatment. The egg is the largest cell in the body. It's full of fluid. So if you're going to freeze it, you need to dehydrate the cell and then freeze the cell. And that is why the success rate of a treatment with an egg donated is lower if you freeze the egg and you obtain that egg from a bank than doing what we call a fresh donation. So our recommendation in general is not to use it, but for several patients could be an interesting option, a good potential possibility. How you select a donor? We provide the option of having donors in our center, or we can refer you to work with an agency. Medically, it doesn't make a difference. The evaluation is always done in our center by our team, including myself and the nurses that are part of what we call the third reproduction party. I'm talking about Marcy, Elena, and Sheila. Even if a donor is coming from an agency, we'll do the complete evaluation. I'm talking about blood work, ultrasound, visits to our office, etc., etc. will review a psychological evaluation, and then will give that donor a final approval. The main advantage of doing it with an agency is mainly the availability of donors. The agency is an organization that could be 1, 2 people, could be 20 people, that they just, regarding donors, they are recruiting donors. They are asking them some initial questions to see if they potentially could be accepted into the program. I'm talking about the age. The ideal age is 30 or younger. There may be mothers before of hopefully a successful pregnancy, having a kid without any malformations or any genetic diseases, no smoking, negative significant family history. And again, all of those questions are exactly the same if the donor comes from the agency or from our pool. When you work with the donor with an agency, that particular donor may be coming from somewhere in Miami, or maybe she may be coming from out of state. So there is a financial implication regarding that. If she's coming from out of the state, then you need to pay for transportation. She needs to stay in a hotel, and some other expenses that may not be included when she lives locally. Of course, also, you have the agency fees. So all of these make the treatment with an agency more expensive. So if you are going to just consider the financial factor, it's more convenient to do it with one of the donors from our pool. But as I said, the availability, the number of donors that we have is relatively limited and decreased comparing with an agency. What do you need to look when you select a donor? What I've seen in my practice is that everybody will say that I want someone that is healthy, and they want to have a healthy child, and they want to have the best possible donor with absolutely no family history that potentially may compromise the health of the child. But you need to be realistic, and it's very difficult to have someone that has absolutely no history. When you talk about personal history, these are young individuals, younger than 30, and of course the donor by itself very likely will not have any significant history. So in that scenario, you're not going to find anything to reject the donor. Why? Because we already did the evaluation. And we are the ones that many times reject donors because we see in those evaluations something that is significant, and we don't even offer you one of those donors. But regarding the family history, is a different story. You are going to have one parent or the grandparents or someone that has something. It could be high blood pressure, it could be someone with diabetes, it could be lung cancer. But if we put everything together and we detect that there is a strong family history of something in particular, some psychiatric diseases, diabetes or hypertension, we may be rejecting the donor for that particular reason. Sometimes could be that the donor has only one relative with hypertension or diabetes, like I said. But if we are treating a couple and the male, for example, has a history of psychiatric diseases, then we may reject that donor for the potential high chance that that child may be affected. So we need to individualize and check each scenario individually. Physical characteristics are something that I think that is the number one factor that the patients are going to look into a donor. Okay, most of the times they want someone that looks like them, something similar to them. We don't make any distinctions regarding race. That is only the patient that will decide how they want to check and select a donor. But I think that the individual factor that is most searched in a donor is to be similar to the patient, in case that the woman is participating in this type of treatment, in cases that there is a gay couple, even if there is no woman doing the treatment, many times they want someone from the same race. Once the donor is selected from the agency or from our office, we need to complete the evaluation. We need to do a genetic evaluation, and once everything is clear, we'll proceed with the treatment. The treatment is basically the in vitro fertilization treatment. Like I said before, we don't share the eggs. All the eggs are going to be allowed to that particular couple, and we're going to see who is going to provide the sperm. In an heterosexual couple, if there are no contraindications, we'll be using the husband's sperm that is going to be injected into her eggs. Most of the patients elect to proceed with the procedure called ICSI, in which the eggs are injected with one sperm in the lab. Those embryos are growing into the uterus for approximately 5 or 6 days, and after that period of time, the embryos are biopsied and are evaluated to look for the chromosomes. The chromosomes are the structure inside the nuclei of the embryo where the genetic information is located. Normally we have 46 chromosomes. There are pairs, 23 pairs, including the somatic chromosomes and the sexual chromosomes. They could be XX for the female or the XY for the male. That's a normal number of chromosomes. You may have an abnormal number of chromosomes. Probably the most widely known is the Down syndrome, where you have the trisomy or an extra chromosome number 21, but there are several other syndromes where there are extra chromosomes that is not the Down syndrome that I already mentioned before, or there may be a missing chromosomes like Turner syndrome, and generally those embryos are not going to be transferred and will be discarded, okay? The embryos, differently from the eggs, could be frozen, and the success rate is not compromised at all. Why is that? Well, the egg is a cell, is the largest cell in the body, is full of water, and the embryo, by the time that we'll do the biopsy and the freezing, we're talking about a biological structure with anywhere from 100 to 150 cells. So the embryo is much more prepared to go through the freezing process without any problems. Particularly since we are also going to check the chromosomes, the process of doing the biopsy, check for the chromosomes, and going to then transfer an embryo into a uterus has a higher success rate than if we proceed transferring the embryo fresh without doing the biopsy. If at any time in the future, and I'm sure that that will happen, we'll be able to have the results of the biopsy in a few hours, we may not even need to freeze the embryo for that particular transfer, and potentially that may have a higher success rate, particularly if the embryos are coming from a donor. Because when you do the regular IVF treatment, the potential problem in that scenario is that the high levels of hormones as a result of the stimulation of the the stimulation of the ovaries may cause that the uterus by itself is not in synchrony with the embryo, and that could be the reason for the decreased success rate when you transfer fresh embryos in certain scenarios. But when you are doing a treatment with an egg donor, really what happened is that the donor was the one that was stimulated with the medications to have her produce several eggs, and that high estrogen level is not going to affect the uterus of the recipient that is being prepared in a different way. The other advantage when you do the treatment on the egg donation and the biopsy regarding freezing of the embryos is that the process by itself of freezing the embryos has no expiration date. What that means is that you may do the treatment now, and like we said, a few weeks or a few months after that, you do the transfer once you have the result of the evaluation of the embryos, and you could transfer that. But the other normal embryos, they could remain open for several months, several years, and you may have a baby now, and in 3 years decides to do again. You just thaw that embryo that you want to transfer and proceed with a new treatment. Knowing the result of the chromosomes also give us the potential advantage, and I said potential because some people may not even want to know, is regarding the sex chromosomes. In that way, you may decide that you want to select the sex of the embryo and specifically request to transfer a male or female embryo. There are certain couples that they come to our center to do the treatment with only that purpose, having 2 or 3 boys or girls at home, and they may do a treatment of in vitro with the sole purpose of looking for an embryo and a baby of the opposite sex. It's not something that everybody is comfortable with, but in our center we'll do the treatment and we have no problems of transferring the embryos of the sex that is requested, okay? Of course, I keep asking you that if you have questions, you start writing them, and I'll be more than glad to answer them, all right? Regarding the coronavirus pandemic that we're going through now, we have established some different guidelines to avoid that during the procedure of the donation there will be no transmission of the virus. Well, before the stimulation of the donor is started, and also in all the patients that are going to have an egg donation, egg stimulation, we're going to do the nasal swab to look for the presence of the virus, what the test that is called by the name of RT-PCR is a technical name. And we are doing here in the office, while likely the donor or the patient is on birth control pills, the testing. After a few days, we get the result. And the idea of doing the test at that point is because if the patient that is asymptomatic tests positive for the test, we will not start the stimulation, and the patient is going to be referred to their primary care physician or the emergency department to be evaluated, follow up, or treated for the presence of the coronavirus. If the patient is symptomatic at any time, we're going to refer her to one of these places to be evaluated. We're not going to be the ones treating you. So that first test is to avoid the patient starting the treatment and using medications. But we're going to repeat the test a few days before the aspiration to be sure that there is not infection at the time of the aspiration, for two reasons. For protection of all of us, all the healthcare providers that are going to be present during the procedure. When the patient is going to be put to sleep, oxygen is given through them, either through a nasal cannula, through the nose, or through a face mask. There is no intubation on this procedure, and that can make small particles of the saliva being on the air, and that could jeopardize the health of all of us, the healthcare providers, even if we use a PPE, like a personal protective equipment that is adequate for this type of procedures. That is one reason to cancel the treatment and cancel the aspiration at that point. The other one will be the potential transmission of the virus through the eggs. As of now, there is not a single paper showing that there is a presence of the virus in vaginal secretions or through any of the procedures of in vitro fertilization. But potentially there may be some papers that show that. Regarding the presence of a sperm, well, there was only one paper in China that they mentioned is the presence of sperm and semen, or one or two patients that they have the coronavirus. But the evaluation was not correctly done, and we cannot say that really, considering there were 4 million people infected, that there is a transmission through the sperm or through the semen. As of now, we are considering that there is no. But, the patients need to understand that this is something new that is constantly evolving, and potentially what I'm saying now may change. To start answering some of the questions, someone is saying that she called yesterday and we haven't returned the phone call. I'm really sorry. We are going to call you as soon as possible. Another patient is saying that she completed all the evaluation to see why she's not pregnant, and she's saying that she still doesn't understand. Well, number one, I need to say that I don't know if we already review all of that evaluation or not, if she's a patient at another clinic or with us. So we need to complete the evaluation, but sometimes there is something that is called unexplained infertility. 15% of all the patients that they are trying to get pregnant will complete the evaluation and will not find any reason to justify why she's not getting pregnant. There is no reason to despair in that scenario. There are treatments specifically designed to treat patients with unexplained infertility. Many times we cannot explain why you're not getting pregnant, but we can give you the guidance and the help to get pregnant with certain treatments. Someone is asking that she's 38 and very healthy, and can I donate my eggs? The age that we use to limit the donation is around 30 or younger. When you are 38, even if you are healthy, the chances of having some type of abnormalities in the chromosomes and the success rate decrease comparing when you were 30. So for a donation that is done through our clinic or with a donor with an agency, we will not accept a donor that is 38. But if this is a directed donation, meaning that you are going to donate for a friend or a family member, in those cases, if your evaluation is normal, yes, we'll accept you for you to donate, okay? And the reason that we put that difference is basically success rate. Success rate at age 38, even if you are healthy and the blood work is normal, is not as close as the same one when you are younger than 30. All right, so now we're going to talk a little bit about gestational surrogacy. Gestational surrogacy is a treatment in which your baby is going to be carried by someone else. You have two types of surrogacy. The traditional surrogacy, in which a surrogate is putting her own eggs, and also, of course, she's carrying the pregnancy. And the other one is the the gestational surrogacy, in which the surrogate is only putting her uterus. We do not do traditional surrogacy, mainly for legal reasons. In the state of Florida and in most states, the traditional surrogate that has placed her own eggs and also, of course, her uterus, have up to 7 days following the delivery of the kid to change her mind and to keep the baby. And for that reason, it's not a treatment that we are comfortable offering to our patients, so we don't do that. The only surrogacy that we'll do is the traditional surrogacy. Some other questions that they are asking me: how many times can I donate my eggs in a year? Well, if you count from the time that you start the stimulation and you go through the process of in vitro and you go through the donation and the aspiration of the eggs, roughly from aspiration to the next aspirations, approximately 3 months will be the period of time that you may do it. So in a year, we could say that you can safely donate 4 or potentially 5 times without any problems. There are no legal limitations to the number that the donor may donate. The limitations are maybe imposed by guidelines or recommendation from the American Society for Reproductive Medicine regarding not donate in excessively times in view of the size of the community where you live. So we can safely say that in a place like Miami, but particularly in our clinic, in which we have a lot of international patients, we can use a donor to donate between 6 and 8 times without any significant problems at all. Someone is asking me if the clinic will be reopening. Well, number one, we were never closed. We continued during the entire pandemic, open, seeing patients. What we were not doing at one point is procedures. We were not doing inseminations, aspirations of the eggs, egg retrievals, or embryo transfers, because we follow the recommendations of the American Society for Reproductive Medicine, and we put a pause in all our treatments. Now, the recommendations changed drastically around 2 weeks ago, and I'm very happy to share with you that yesterday we already did our first retrieval, and we have several more this week, and several embryo transfers are already being scheduled. So we are seeing patients, we are seeing new patients, and we are offering, like we put in our social media, a new normal. When the patients come to the office, they will be asked questions regarding temperature, potential exposure to COVID-19. In the waiting room, we respect the social distancing. We ask you to use a face mask during the intervisit. We ask the partners to wait in the car, and so on, to start learning what is this new normal and this new regulation and recommendations that we have. So if you are not our patient, we'll ask you to call us and to schedule an appointment. Another question is if it's possible to conceive multiples or hyperovulate by following ovulation. When you use injectable medications that you normally use during the in vitro fertilization, you can do 2 types of treatments. One is the inseminations, the placement of sperm inside the uterus. The other one is the in vitro fertilization. When you do insemination, and particularly the patient produces several eggs, that is when you have a very high risk of multiple pregnancy, and could be high order pregnancy of potentially triplets or quadruplets. When you do in vitro fertilization, that is basically related to the number of embryos that you are going to transfer. And their recommendation so far, particularly if you biopsy those embryos and they have normal chromosomes, is to transfer no more than 1 embryo. We still transfer 2 embryos if the patient is requesting that, but let me tell you, and believe me, not after a long conversation where we expose the multiple risks related to the decision of transferring 2 embryos. Basically, the most important one is a multiple pregnancy and all the complications that may be present during the pregnancy. Preterm labor, preterm delivery, C-section, diabetes, gestational diabetes, hypertension, preeclampsia, and so on, okay? So that is something that we do not recommend, but potentially individually will do it. This is our decision based in our experience and based on the experience of the American Society for Reproductive Medicine. So going back to the treatment of surrogacy, here we do not have surrogates in our center. We do not present or offer surrogates to our patients. We have the option of the patients bring their own surrogate that they may have met through social media or if it's a relative or a friend. But it's something very difficult to be able to manage adequately if you want to do that on your own and try to get the adequate surrogate. That's why in these scenarios the recommendation is to work with an agency. When we talk about agencies, we talk about again the same type of agencies that they offer you egg donors. They may offer you a surrogate. We work with several agencies, just to name a few. Open Arms Consultants, we've been working with them for a long time. family source consultants, egg donor solutions and surrogacy solutions, circle surrogacy, growing generations. Some of those are out of the state and they are more infrequently, but the first three that I mentioned, we've been working for a very long time. So we determine the indication to do the surrogacy. It's very easy if you have a single male or a gay couple coming that they want to have a kid, that they just can provide the sperm. But the indication sometimes is more in a gray zone when you have a heterosexual couple, and it's very clear if, for example, the woman has a hysterectomy, surgery in which the uterus was removed, but when they have previous treatments and there is an implantation failure, transfer of embryos and with no success, many times we need to discuss when is the limit and when is appropriate to proceed with the surrogacy treatment. But basically those are by far the most commonly found reasons to do the surrogacy. Of course, then you have medical contraindications for pregnancy. A patient that, for example, has a myocarditis during the pregnancy or postpartum, that is a very serious condition, inflammation of the muscle of the heart, or hepatic insufficiency or renal insufficiency, and be waiting with waiting list for a renal transplant, and so on. So once the indication is clearly established, we determine from where the eggs are coming from. Could be from an egg donor, could be from the patient by itself. The patient completed treatment, then we have the embryos following a stimulation that was done in the same way that we did it for the egg donor. The embryos are frozen, and at the same time we could be looking for the surrogate. The age requirement of the surrogate is significantly different than for the donor. The American Society for Reproductive Medicine has an age range of 21 to 45. In our center, we're more strict than that, and we say that up to 40 is what we recommend. We consider that after 40, there are certain problems with the patients that they are considering being a surrogate, like adenomyosis, the presence of some type of scar tissue, endometriosis on the wall of the uterus, that may jeopardize, decrease the chances of success. We accept potentially surrogates older than 40, particularly if there is someone that is known to the patient. We can even go to 50 or older than 50 to accept in that situation. But we need to individualize each one of the scenarios. Once the records are reviewed, and those records, believe me, they are extensively evaluated. We try to get as many as possible with the help of the agency regarding previous pregnancies, because the other condition that we institute and must be really completed is that she must have at least one previous pregnancy that was uncomplicated at full term. She may have had a C-section. The C-section by itself will not be a factor for exclusion. But if during the C-section, for example, she lost 3 liters of blood and has to receive several units of red cells, and she was admitted to the intensive care unit, that potentially may be grounds for rejecting a surrogate. Like I said before, the surrogate, if it's coming from the agency, they are the ones that they do the initial search, asking their age, if she was pregnant or not before, what happened during the pregnancy, if she's healthy or not, Smoking is another of the conditions that will exclude automatically the potential candidates. And those profiles are going to be sent to our team for us to evaluate them from the agency and decide if it's a potential candidate is a good candidate or not. We are a center that is characterized by really strict requirements in accepting a donor and mainly a surrogate. We will not bend over, we will not really have requirements that we will not look in detail just to speed up the process. We really want to prioritize the excellence in our treatment and not the speed. We think that the long-term happiness of that couple related to a healthy pregnancy is the main goal in our center when we decide to accept or reject a surrogate. And that is what I think that is important to understand when we may potentially reject a surrogate. Regarding the waiting time to get an appropriate surrogate, you need to individualize that and talk to the agencies, and depending on the requirements that you may have or not have, is that it takes some time, okay? One question someone is, if I know the agency donor concierge, if they are good or not. As far as I know, if I not mistakenly identify them, basically this agency is not an agency by itself. Basically they connect with several other agencies looking for the potential donor or even surrogates. So, but agencies, there are several ones in the entire country, and I may be giving you the wrong information, but as far as I remember, they are trying to connect you with an agency that have adequate donor or surrogate for you to proceed with the treatment. You can email us and I can give you the correct information. How many times can be a surrogate in my lifetime? Well, at least you need to have one previous uncomplicated full-term delivery. And of course, not smoking, being generally healthy, having a healthy relationship between your height and your weight, do not use drugs, etc., etc., etc. Regarding how many times besides that, we're talking about no more than 3 previous C-sections and no more than 5 previous vaginal deliveries. If you have one kid and was born through a C-section and then you're going to be a surrogate again, and each one is going to be delivered by a C-section, you cannot be having in your history no more than 3. So potentially you can do it 3 times, okay? There are no extra limits or different limits if you were a surrogate or not, okay? Someone is telling me that she's a surrogate. Well, I answered the question about the donor concierge. How long it takes all of this? Well, when you do the treatment, how long it takes? If you're talking about an egg donation, the treatment itself may be 6 weeks to 8 weeks, including the birth control pills when they are taking them. If you're talking about the surrogacy, what takes the most is looking for the correct surrogate and get the surrogate. That may take some time, but the preparation by itself is also 6 to 8 weeks. Someone is asking if you have a donor that has grandparents with diabetes. The question was asked in Spanish in the way that it was asked. If there are two grandparents with diabetes is when we are considering potentially that we need to look at that. If there are three or more, it's absolutely something that I would recommend not to use that donor. Okay. Susana is saying that is waiting for the next console. Yes, I know you very well. I'm also waiting to see you very soon. So going back to the surrogacy, because I think that we are approaching the last 15 minutes of the Instagram Live. Once the transfer is done, we'll do the monitoring during the first trimester. First with a couple of ultrasounds, and then with the blood work, knowing that the estrogen and the progesterone level is adequate. Regarding the coronavirus, similarly to the scenario with the egg donors, when I have the surrogate on birth control pills before we start the Lupron, we'll do the swab testing, and if it's positive again, we cancel the treatment, and we'll do another swab testing to try to detect the presence of the virus a few days before we'll do the transfer itself. You need to understand that due to the nature of this type of infection, even if you do the testing and you leave the office and you go to the parking lot, you may contract the disease over there, okay? So you need to really continue to do the social distancing and washing your hands very frequently and using the face mask and so on. I wanted to share also something regarding the legal aspects of doing the surrogacy and egg donation here, particularly from the patients that they are not from the US. I'm talking about all the patients that we have from Europe, from the Caribbean, and from Central America and South America. The law in the state of Florida to do surrogacy is excellent. In the Florida statutes, it's clearly stated that the surrogacy is a treatment that is allowed. The immigration status or the visa status of the intended parents is not a factor. What I'm talking about is that there may be tourists on the B1, B2 visa, there may be holders of a green card or being permanent residents or American citizens, is for all the same. These treatments are included in the Florida statutes, and the parents are going to be the intended parents. In the birth certificate is where they are going to be their name without any problem. For those patients that they do not live in the US, the current pandemic situation, added the scenario that the traveling to be present at the time of the delivery and to be with your child is particularly challenging. But even now that we are in the middle of the pandemic, with the airports closed and some countries with absolutely no flights, we have couples that they were successfully traveling to the US and they were present for the deliveries. Only one couple was, for a personal reason, not able to travel with time, but they were successfully traveled from Argentina, I think that around 10 days ago. Now they are in quarantine, waiting to be united with the baby that during that period of time was with the surrogate following the delivery. Someone asked me again how many times donate the eggs. We said 4 or 5 times during a year. For surrogacy, when I get the injections in the mail, how long do I have to take them? Well, the injections that we may be talking about is injections that you do intramuscularly. For surrogates, that could be the progesterone, is one of the hormones to support the pregnancy. It's anywhere from 7 to 9 weeks roughly, but that's not the only way to be treated. Sometimes what you can do is instead of the injections, if you don't want to do it, that has the only advantage of do it once a day and that's it. You can do a capsule by mouth twice a day, and a gel that you place in the vagina that you do it twice a day most of the times. And the success rate is very similar. There is not really a difference at all. Esteban is saying hi to me. She's talking about the little Pola that is 4 months old. I know them very well, and I really want to see them soon. Someone else is saying hi. Ariana is saying hi, how you doing? Thank you for all these messages that you are saying. They are talking about from Argentina. They are saying hi, and they are talking about another agency, Open Arms. Yeah, it's one of the agencies. If you are considering being a surrogate, you can be with them. So to put everything together and to finalize soon, we were talking about then egg donation. We chat a little bit about how to select the donor, what are the important things, what is our participation, what is the agency participation, how is the procedure, what you do the biopsy on the embryos. You can do the sex selection on those same embryos. The embryos are going to be frozen. You can keep them for a long time. Regarding the surrogacy, we talk about how you select the surrogate. We talk about the characteristics of a surrogate, how many times you can be a surrogate, how many times you can be a donor. We talk about the everything regarding the legal aspect of the surrogacy and how Florida is a very strong place to be at ease, knowing that the law will really cover you regarding the surrogacy. And now I think that if you are all saying, and if one of my kids is watching this, he say hi to you, David. I need to ask him how he did in English, if you guys understood what I was saying, because at home they are permanently criticizing my accent. My daughter Talia also say hi, and probably my other youngest kid Matthias is probably somewhere there, and my wife Viviana. They're asking how much an IVF procedure cost. Okay, approximately 15-20% of the insurance may cover those treatments. Egg donation and surrogacy are never really covered. Unfortunately, they are very expensive. If you talk about the in vitro fertilization procedures, there are different packages, there are different alternatives, but there are several $1,000s. Could be around 18 or 19, but I'm not the one managing those things in my office, so you're more than welcome to contact us and we'll share all of that information with you. When you're talking about a treatment with egg donation and surrogacy, if you're going to put everything together, I'm talking about the egg donation, the agency fees, our fees, the obstetrician fee, the hospital fee, the attorney fee. You're talking about $120,000 or potentially more. If you are able to provide a surrogate and you have a private agreement with them, that is a single factor most important to try to decrease the cost, okay? But unfortunately, they are very, very expensive treatments. Someone was asking me why do a treatment here and not do it in Latin America. Well, for several reasons, I think. We've been doing this for over 20 years, so we have a lot of experience. This is not just doing an in vitro fertilization procedure and put the embryo in another uterus. We have experience identifying the surrogate. We know how to evaluate them. We know what to look in someone to tell you that it's a good candidate or it's not a good candidate. We have a team that is working with us for a long time, and they do the psychological evaluation. We review that. We have ample experience on that. The agencies, they are working on the social evaluation of the surrogate. They have a specific follow-up. They have a determined plan that they're going to be with you during the entire process, and you're going to have during the entire process someone with you guiding you in your language, okay? Either if it's Spanish or Portuguese or French or English or wherever you feel more comfortable, you will have someone to communicate very well, so you will not be alone at all during the entire process. From the legal point of view, each one of the 50 states is totally different. Let me talk about Florida first. As I said several times, the statutes in Florida cover you for the surrogacy. The surrogate has absolutely no right regarding trying to claim maternity over the child at all. Of course, she has all the obligations about behaving correctly during the pregnancy and following the medical indications, but also the intended parents, they have the obligations of paying adequately and provide during the pregnancy. So Florida is a great state for surrogacy, even if you are single, if you are male, female, if you are a gay couple, straight couple, you're married, no, you're not married, everyone can do it safely in Florida. Recently, I was heavily criticized by people in social media that was calling me like if I were a pimp, managing the surrogates as if they were prostitutes, because instead of renting their vaginas, I was renting their wombs. And let me tell you, nothing more away of what truly happened, okay? The surrogates are not concentrated in a camp away from their families and not allow them to live with chains, leaving them next to their beds, okay? They are individuals that they have all the rights that they need to continue with their normal lives, and if they are not really accepted from the beginning, is because there was something that was wrong with their evaluation. And once they are in, this is a team effort for everybody to have a successful pregnancy. Well, we are almost finishing. I wanted to say thank you to everybody. Thank you for your support. On Thursday, today is Tuesday, on Thursday I have another Instagram live in English. This will be regarding infertility, pregnancy, and anxiety and COVID-19. I'll do it with a psychologist that I've known all of my life because he's my brother, Eduardo Akerman. Will be on Thursday live at 12. I hope to see you there, and if you have English questions, we'll answer them. Thank you very much, and we'll see you soon. Bye.